This video will describe the tenets and techniques of performing a mechanical thrombectomy. Aspiration thrombectomy will be described first through a case example. This is the case of a 59-year-old man who presents with acute aphasia and right hemiplegia with an NIH stroke scale of 20. He presented 4 hours post-symptom onset and received intravenous TPA following a non-contrasted CT head. A CTA demonstrated a tandem left cervical and intracranial internal carotid artery occlusion. Careful analysis of the initial non-contrast CT head reveals only a small early infarct core. The sagittal CT angiogram demonstrated the left cervical ICA occlusion. And the axial images demonstrated a cutoff of the contralateral supply across the A1, suggesting a concomitant ICA terminus occlusion. Given the favorable aspects score in the early time window in conjunction with a large clinical syndrome, the patient was taken for thrombectomy. The initial common carotid artery injection redemonstrated the cervical ICA occlusion. After crossing the cervical carotid occlusion with a microwire and microcatheter, the proximal ICA was treated with angioplasty and stent placement under distal protection. A post-stenting angioplasty was performed to maximize stent expansion. Post-stent angiography demonstrates a patent cervical ICA but confirms an ICA terminus occlusion. A microwire is then used to traverse the thrombus to achieve distal access into the M2 division. The microcatheter is then advanced into the M2 division. Then the aspiration catheter is advanced over the microcatheter to the level of the thrombus. The microwire and microcatheter are then removed rapidly under manual aspiration with a 60 cc syringe. Post-aspiration angiography reveals a TQ2B reperfusion following a single pass. Post-intervention MRI reveals a stable small core infarct suggesting preservation of the prior ischemic penumbra. Following inpatient rehabilitation, the patient recovered to a normal neurologic exam. Next, stent retriever thrombectomy technique will be discussed through a case example. This case involves a 74-year-old woman who awoke in the morning with aphasia and right hemiplegia. She had an NIH stroke scale score of 14 and was last known normal 10 hours prior to admission. She was found on CT angiography to have a left M1 occlusion. Initial non-contrasted CT head demonstrates a small early infarct core. CT perfusion imaging better demonstrates a small infarct core significant mismatch. Patient was taken for endovascular thrombectomy. Initial left ICA angiography reveals a M1 occlusion. A microwire is used to traverse the thrombus and achieve distal access into the M2 division. The microcatheter is then advanced into the distal M2 division. A stent retriever is deployed across the thrombus and the microcatheter is removed. The aspiration catheter is then advanced over the stentriever under aspiration. The stentriever is then withdrawn into the aspiration catheter, which is subsequently removed under continuous aspiration. This technique resulted in a TQ2B revascularization. Post-intervention MRI revealed a stable small infarct core. The patient recovered to a mild hemiparesis and regained baseline language function.